At large, as mentioned earlier, that one of the goals of the oncology care model is improving the appropriateness of care, and recent research on the overuse of low-value cancer services and drugs can really help inform efforts to partner with physicians to reduce inappropriate care. And we're pleased to have Allison Lipitz-Snyderman with us today to share some of this research. She's the Assistant Attending Outcomes Research Scientist at Memorial Sloan Kettering Cancer Center, and NIHCM Foundation provided grant support for Allison's research on this topic through our investigator-initiated research grant program, and we're so grateful that she's able to join us today to discuss her work. Allison?
Great. Thank you for having me. My name is Allison Lipitz-Snyderman, and I'm a health services researcher at the Center for Health Policy and Outcomes at Memorial Sloan Kettering. Today I'll be talking about my research on physician-driven variation in low-value healthcare services in oncology. So thank you to the NIHCM Foundation for supporting my work, which was also supported in part by the Cancer Center Support Grant to Memorial Sloan Kettering. I'd also like to thank my study collaborators, who are a multidisciplinary team of biostatisticians, health policy and health services researchers, and clinicians. I have no disclosures to report. So low-value service use is widespread in oncology. And when I'm talking about low-value service use in this context, I'm talking about those types of services for which the anticipated harms of use outweigh the anticipated benefits. For example, cancer-directed therapy for patients with solid tumors with low performance status. So why does this matter? Low-value services and drugs are associated with patient harm, excess costs to patients in the healthcare system, as well as other negative effects. And several studies have demonstrated wide variation in the use and prescribing of these low-value healthcare services and drugs across the U.S., including differences by region, big variations by individual hospitals, and also there's a growing body of literature demonstrating that at the individual provider level, there's also large variations. So why do we care about variation? It's because it suggests that there might be opportunities to intervene, potentially to standardize practice to help maximize outcomes for patients and other stakeholders. So the focus for today will be on the individual provider level, so specifically focused on the physician. And the reason we're focusing on the physician is because physician level represents an actionable level of intervention. Also, the physician is involved at that point of decision-making of whether or not to use this low-value service. So the critical question that I'll be discussing today is what drives physicians to prescribe these low-value healthcare services and drugs? And I'll be reviewing two questions. The first is, do physicians exhibit consistent behavior regarding the use of these low-value drugs? And secondly, does oncology practice setting influence physicians' behavior? So first we'll be talking about the first research question. Do physicians exhibit consistent behavior? And we're focused on the clinical context of cancer care, since cancer care represents an intense period of potentially harmful and costly healthcare services and often a lot of uncertainty in decision-making. A clear understanding of treatment patterns of physicians' behavior is needed to help inform the direction of interventions. So, for example, if we can demonstrate that service use is consistent for individual physicians, in other words, they're always prescribing the same low-value drugs or not, it suggests that the intervention should be physician-specific and targeted potentially to these high-user groups, and also that we can learn from the more measured users. If service use turns out not to be consistent by a physician, it suggests that these interventions should be service-specific instead. So the hypothesis of our study is that physicians' practices is consistent. Specifically for this study, our hypothesis is that physicians' past use predicts current use. And as you can see on the left-hand side of the slide, our hypothesis around the correlation between use of these imaging tests, we see that Dr. A prescribes this non-recommended imaging test both for patient 1 and patient 2, and Dr. B does not prescribe that imaging test for patient 1 and patient 2, and so on. And this suggests this idea that use of this low-value test is consistent, a habitual behavior. Whereas on the right-hand side, if our hypothesis is not supported, we might see that this imaging test would be randomly distributed throughout these patients and not really directly connected to the individual doctor. Specifically around our study, we're interested in looking at whether what happens with patient 1 might predict what happens to patient 2. So to test our hypothesis that these physicians exhibit consistent behavior regarding these overused services, we took a look at some of the items from the ABIM Foundation's Choosing Wisely campaign. And this campaign asked medical specialty societies to suggest items that should be questioned by physicians and their patients. So we included 5 of these items that we were able to measure, one of them including from ASCO, don't perform PET-CT and radionuclide bone scans in the staging of early breast cancer for patients at low risk for metastases. So that's one example, and these are 5 examples in cancer care of things that we might call low value or potentially overused services. So to address this issue, we use the SEER Medicare population-based data set. And this data set links information from SEER registries, which are cancer registries, which include information on patients' site of cancer, their stage of disease, their time of diagnosis, things of that nature, links it up with claims from Medicare, which includes use of health services specifically, and links up that data for patients who reside in SEER regions. And that includes about 28% of the U.S. population of cancer patients are in SEER regions. So we use this data set to create our study sample of Medicare beneficiaries who were ages 66 and older, diagnosed with cancer between 2004 and 2009. And back to our earlier example, we specified the study sample based on the specific measure that we were looking at. So for example, in the item early stage imaging, we included patients with stages 0 to 2 breast cancer with surgery within 6 months of diagnosis and no neoadjuvant treatment. We assigned each patient to an accountable physician for the analysis. So in this case, we assigned the patient to her surgeon. We conducted 2 main analyses for this project. One, we used multivariable logistic regression analysis using a random effects model to allow us to find out how much variation there was between individual physicians. And then the second piece, which I describe here, is looking at that specific outcome of receipt of low-value services conditioned on the physician's last patient having received that service. So as you recall from the illustration, it's basically, does what happened to patient 1 predict what happens to patient 2? So for that analysis, we excluded patients whose physicians only had 1 patient in the data set because you needed 2 patients to be able to link up a lag variable there. So this is a table of our results. We found that there was significant variation between physicians for each of the 5 services that we looked at in particular. As you can see in the example here for imaging for early-stage breast cancer, we had over 89,000 patients in the data set, representing over 4,000 total physicians. About 14% of patients received this low-value imaging, and we found widespread support for our hypothesis. We found that the odds that a patient received that imaging test was 3 times higher if her surgeon's prior patient also received that imaging. And as you can see from the other examples, we found similar support for this idea that this past behavior is predicting what's happening. This suggests the idea that we're seeing consistency within physicians' behavior regarding a variety of low imaging tests. So this leads us to the question of why. What's driving this behavior? So it could be many different things. One area that our research team was interested in looking at was what's the influence of oncology practice setting on physicians' behavior. And so why oncology practice setting? So we know that there's been a shift in outpatient oncology care from independent physician offices to hospital outpatient departments. We've seen that over the past decade. There's differences between these settings, including different reimbursement structures for some of these very expensive drugs. This has prompted questions about the impact of setting on cost and quality. And there's been limited work done to assess the impact of setting on treatment patterns specifically. And so that's what we were interested in delving into in this part of the study. So our clinical context in this case was outpatient cancer care for patients with advanced disease. And we focused on patients with advanced disease because there's many very expensive drugs for patients with advanced disease that are likely to have limited or no added benefit to the patient and may even cause harm. So it's a ripe area for addressing overuse issues. So our hypothesis for this piece of the study was that physicians in private practice oncology settings order more low-value, expensive drugs than physicians in hospital outpatient settings. We used similar methods. We used the SEER Medicare linked data set for this analysis, focusing on Medicare fee-for-service beneficiaries diagnosed specifically with advanced cancer between 2004 and 2011. And again, we created separate cohorts of patients based on who would be eligible for that specific drug that we were looking at. And in this case, we chose 4 different drugs that would likely be considered to be low value for patients with advanced cancer. ESAs and GCSFs are supportive care drugs that would be relevant for patients with advanced solid tumors. A variety of solid tumors were included in that grouping. And then combination chemotherapy and nab-paclitaxel for patients with advanced breast cancer. So as you can see here, there's support for our hypothesis. We found that the use of these low-value drugs in this setting was higher in physicians' office settings compared to their use in hospital outpatient departments. This is unadjusted for any patient characteristics. So for example, for ESAs, we saw that there were 16% of patients had ESAs that were low-value ESAs in the physician's office setting compared to 9% in the hospital outpatient department setting. So this graph represents the adjusted analysis that we did with these same drugs. And again, we found support for differences in practice setting. For our 2 supportive drugs, ESAs and GCSFs, we found these to be statistically significant in this model. For the therapeutic approaches, combination chemotherapy and nab-paclitaxel, they were in the expected direction but not statistically significant. Also, as you recall, this was among a smaller subgroup of patients, just patients with advanced breast cancer compared to the total. So what are the implications? So the findings support the notion that physicians exhibit this consistent behavior with regards to using these low-value services in oncology. And our findings provide some early insight into these patterns from Medicare claims. But we still are left with this incomplete understanding of the mechanisms through which these patterns exist. We don't know why. We found support for one structural characteristic, oncology practice setting, that it mattered in that context. But we don't know, is it the reimbursement? Is it that hospital physicians who practice in hospital outpatient departments may be exposed to more to what their peers are doing? They might have more standardization in terms of policies. There may be other differences between physicians. We don't know. That's an area for further study. In general, further study, we believe, is warranted to try to understand the mechanisms through which things like setting and other practice patterns might influence physician behavior so we can translate those into effective interventions. What we found is that there are many implications for interventions at the physician level, such as trying to de-incentivize the use of these non-recommended low-value services and drugs that could be used to reduce avoidable patient harm and cost and ultimately to maximize outcomes for patients with cancer. So thank you for your time. I'm happy to answer questions after the presentation.